The objective of this case report is to illustrate the cause of May-Thurner syndrome, as well as diagnosis, workup, and management, and screening. This case presentation illustrates a 51-year-old man with past family history of chronic bilateral venous stasis ulcer who presented with left plantar foot wounds due to recurrent bilateral peripheral edema. The patient complains of severe left lower extremity swelling that had worsened over the last 6 years. The patient began to experience severe skin breakdown with seeping of the skin and 3+ pitting edema to the mid-thigh. This chronic peripheral edema caused chronic ulcers on the left calf, which required debridement. Lower extremity duplex revealed elevated peak systolic velocities within the left common deep femoral arteries and left proximal mid-superficial femoral arteries. The patient was diagnosed with May-Thurner syndrome via ultrasound-guided IVC venography and intravascular ultrasound. It was treated with stenting of the right common iliac vein, the right external iliac vein, and the left common iliac vein. Post-operative follow-up revealed clinical improvement of the bilateral lower extremity edema. Results of this intervention. The chart below illustrates pre- and post-operative right common iliac vein surface area and diameter. Image 1 shows two outlines, a blue outline and a green outline. The blue outline shows compression of the right common iliac vein, and the green line shows the diameter of the respective vein. Preoperatively, the surface area was 220.1 millimeters compared to postoperative 352.3 millimeters after stenting, which resulted in improvement of the obstruction and clinical improvement in our patient's stasis. Discussion. The cause of MTS is unknown. However, the most common variant is the compression of the left iliac vein between the right common iliac artery and the fifth lumbar vertebra. This rare cause of the venous stasis is known to cause proximal DVTs, or deep vein thrombosis, via chronic venous mechanical compression. In rare circumstances, it may be acquired by iliac artery stenting that compresses the iliac vein. This case report is presented to inform clinicians of a rare but serious cause of chronic venous stasis. One may attribute chronic venous stasis to venous insufficiency. However, in this case, conservative management was futile, as the cause of the stasis was due to venous compression via proximal artery rather than insufficiency of the respective vein. These patients, however, are at an increased risk for DVTs and should be assessed with lower extremity ultrasound. In conclusion, this case report allows for clinicians to explore further workup in patients that have chronic bilateral peripheral edema that does not improve with either medical or conservative management. Patients with May-Thurner syndrome often present with lower extremity DVTs, and therefore workup with venous ultrasound should be considered in patients that are high risk. Thank you.